Welcome again to Free Associations from the Boston University School of Public Health, the Medical Journal Club podcast for anyone who's ever been really confused by the latest health study. I'm Matt Fox, professor of epidemiology and global health, and we are here in the Boston University Godley studio. Today in our first segment, our Journal Club segment, we are going to talk about an interesting new paper that asks whether teaching primary school kids in Uganda to evaluate health claims, something that we care deeply about and is a major theme of this podcast, whether it has any impact on kids' knowledge, intended behaviors, and self-efficacy related to evaluating health claims. We'll dig into what that means. And then in our second segment, our deep dive segment, we'll talk about how we generalize from one study to larger populations. And then in our third segment, our amazing and amusing segment, we are going to talk about the things that grabbed our attention or just distracted us from our real jobs. But before we get into it, we want to take a second to remind you about Population Health Exchange, the Boston University School of Public Health's resource hub for lifelong learning. Find out more at www.populationhealthexchange.org, where you'll find this podcast as well as many other population health learning programs and tools. Now, let me introduce you to the team. I am joined in the studio by Dr. Don Thea. Don, can you introduce yourself?
Hi, Matt. Don Thea here. I'm a professor of global health in the Boston University School of Public Health. I'm an infectious disease doctor, and I've done my research mostly in Africa and South Asia on HIV transmission and pneumonia.
And I'm joined by Dr. Chris Gill. Chris.
Hey, Matt. Sure. My name's Chris Gill. I'm an associate professor in the Department of Global Health. I'm a infectious disease doctor by training, and also have spent most of my career studying HIV and respiratory pathogens and vaccines.
And apparently bats. So let's get into it. In segment one, we are going to take on a paper that was brought to our attention by what I can only refer to as our producer, because I don't know what else to call you, Leslie Talalian, who brought us a study which asked the question of whether teaching kids how to evaluate health claims makes them better consumers of health information. The article was published in The Lancet, and the title was Effects of the Informed Health Choices Primary School Intervention on the Ability of Children in Uganda to Assess the Reliability of Claims About Treatment Effects, a cluster randomized controlled trial. So it's a design we haven't talked too much about before, so we'll get into that. Before we do, I always give you the headlines, and this one really just needed one to sum it up. So this was the headline in Vox, and I'm not. We have determined from the last podcast I'm not allowed to say the last word in full, so we will just abbreviate and say this researcher may have discovered the antidote to health BS. All right, so. Before we jump into the how we feel about it, Don, can you give us an overview of the study, what they did, what they found, and was it a worthwhile study to do?
Sure. Thanks, Matt. I really like this study.
Yeah.
I thought this is one of the coolest studies that we have so far evaluated. This was a study that was done by a group of researchers from Uganda and from Norway. And the purpose was, as Matt had mentioned, was to show that there is a primary school curriculum, which they devised, which could be taught to fifth years who are kids that are around 10 to 12 years old in Kampala over one semester that would have an effect on their ability to make decisions about health issues. And we know from having worked in developing countries as well as in the United States that health behavior is really a very, very important component in terms of population health. And our ability to affect how people evaluate the evidence that's at hand and make rational decisions about health is critically important. Nobody else has ever even considered addressing this issue with kids. Much less kids in an environment like Uganda. And these guys have done, I think, a really fantastic job of putting together a highly complex study to try to address that. So what did they do? So this is a cluster randomized controlled trial, which means that the intervention and the control is implemented in clusters. And those clusters are evenly divided between the intervention and control. And by clusters, what they did was that they chose schools randomly of the schools that were available in Kampala, Uganda, and they then divided them up into, as I said, intervention and control groups. And they would have this curriculum that they developed be taught by a teacher during the course of one semester in a particular school. And because they didn't want there to be an influence of a teacher teaching it and a teacher not teaching it in the same school, because that would entail some difficulty and maybe some bleeding over of the effect. We'll talk about that a little bit later. What they did is they had 2 or sometimes 3 teachers in a particular school teaching this curriculum. And the curriculum was essentially 9 classes, 80 minutes each, over the course of 9 weeks. And the curriculum was devised to really convey 12 key concepts. And there were things like treatment might be harmful. Widely used treatments or treatments that have been used for a long time are not necessarily beneficial or safe. Conflicting interests may result in misleading claims about the effects of treatments, or evaluating the effects of treatments requires appropriate comparison. So in essence, what they were doing was they were almost teaching a public health course on how to evaluate science. And they
essentially it was this podcast.
Yeah, basically this podcast.
Skepticism.
What we're trying to get across in this podcast, but they distilled it down into these very workable classes. And then at the end of that, what they did is they gave these kids a multiple choice questionnaire, and those questions were not a regurgitation of what they had learned, but it was really to take the lessons that they had learned and apply them to new situations. And then they graded the results of those questions, and they got truly remarkable results. Really, to boil it down, the mean scores between the control and the intervention group in terms of the number of those 24 questions that were correct were 43% in the controls got the answers correct versus 62% in the intervention group. And when they determined whether the kids, based on the results of these examinations, had mastery of the material, which means that they got 20 out of the 24 correct, only 1% of the children in the control groups had mastery of the material versus 19% in the intervention group. So it was a remarkable demonstration that you could actually take these 10 to 12-year-old children in a place like Kampala and teach them enough fundamentals of public health and scientific inquiry so that they could actually synthesize and use that information correctly.
Yeah.
Whether this results in a change in behavior is a whole nother question, and that's not what the study was set up to address. But I've never seen a study like this, and I would have predicted from the very beginning that they wouldn't be able to accomplish this.
They would have failed.
Yeah. But I think it was a rousing success.
Yeah. Chris, give us your take on, was this a good study? Was this done?
My enthusiasm is similar to Don's. I thought this was
enthusiasm cup runneth over.
It was clever. It was a brilliantly designed trial and novel and persuasive and
well executed.
Really, incredibly well executed. I commend them. I mean, this is, I think, how many kids? 10,000 kids?
Yeah.
In 120 schools? I mean, that's impressive.
And fundamentally, what they're trying to do is answer the question: can you train scientific literacy and skepticism in school-age children? The answer turns out to be yes. You can. It's and the building blocks for that were not esoteric. They did not require a PhD in epidemiology or going to medical school.
There goes my job security.
Unfortunately for us.
But it's the basic concepts that we, in essence, teach.
Yes, it's true.
Oh, yeah, no, so my favorite one is personal experiences or anecdotes are an unreliable basis for assessing the health effects of most treatments, which we teach as, that's the tyranny of the anecdote.
Well, I met a guy who said that's not true.
Oh. What is not true?
He said what you just said is not true.
What?
And who was this guy?
I met him on the subway. He seemed very reliable.
Real
I see.
Authoritative voice.
So this is somebody who believes that the plural of anecdote is data.
That's right.
Got it. I don't subscribe to that theory. But overall, so you see this one as a rousing success.
Yeah, and it's it gets to some of our themes in this show, which is in this podcast, which is that science is tricky, and just because science is not always right doesn't mean that it is wrong. It just means that No, that's
Oh, boy.
what we say.
Thank you, Yogi Berra.
It's not always right, but the fact that it's not always right doesn't mean it's always wrong.
Right.
And you
Right.
have to be an informed, cautious, skeptical, thinking consumer to make sense of this. And in fact, and this is the beautiful point of it, is that the skills that you need to become an informed, thoughtful, skeptical, consumer of science are not particularly esoteric and can be taught.
Yep.
And a lot of it comes down to common sense. I just loved it.
No, exactly. And I think that's how we, to a certain extent, consider public health. It's applied common sense. And that's what these guys were being taught.
I would like to think it's a little
Come on. Yes, it is.
more than that.
I would love it to be so.
It's rigorously applied common sense.
Rigorously applied common
But
sense.
it's common sense.
Why? You're giving away all our secrets here. We're not going to have jobs after this. All right. Let me give a slightly skeptical take then, because
There were some flaws.
There
we
are
need
some,
to talk about.
There's some limitations. There are some flaws, and I share your enthusiasm. I thought it was a great study. I really commend these authors. I mean, this is something that took a lot of effort to design this curriculum, to implement it, to train the teachers. So there is this concept that economists have gotten into lately, where have you heard about the randomistas?
Yes.
The randomistas. This is like the pejorative term that they use in the economics world for this love of randomized trials that has started to filter into the economics world from the public health world. And the criticism stems largely from what I can tell around two things. One is ethics. Is it ethical to do a randomized trial of something that is good for people? So let's say, for example, let's say we decide that we're going to do a randomized trial, which is all the rage now of conditional cash transfers, right? We're going to give people money in exchange for some health behavior. Well, it's always a good idea. I mean, how can it be harmful to give people money? There is some benefit there. So is it ethical to do a test of whether or not it can bring about other behaviors? That's not an issue here, I don't think, at all. But the second issue is the issue of whether or not the information that we get of randomized trials of behavioral interventions are we learning enough from the interventions, because the effects of those interventions are very specific to the population in which they are being delivered and the way in which they are delivered. And so do we get enough out of this to learn that this is something we should be doing everywhere? Or is it really a function of, if you have really energetic people, they can take this curriculum, give it to some really enthusiastic teachers and get them all excited, and you'll get some benefits. But then when you walk away and you leave this program to people to implement on their own, maybe it sort of dies off and you don't get the benefits. So I don't know. Do you have thoughts on whether or not we should really be doing trials of behavioral interventions like this if they're not generalizable enough?
Well, that was the first thing that popped into my mind as I was reading this. Is like, why can't we do this here in Boston, or or in my hometown of Lincoln? Why can't we do the same intervention and see where it leads? But my skepticism is that we are primed to fall into traps. And so even though we can sort of create physically, I'd say, cognitive dissonance traps. There was a famous magician called the Amazing Randy, who was also part of the skeptical inquiry movement. And
Amazing Randy.
And he
got it. Hold on.
He would do this demonstration of astrology with university students in the University of Florida every year. And I've actually adopted this in my course and taught it for several years, thinking the Amazing Randy must be so good at like creating this effect that it's just the unique Randy effect. But I have replicated this 3 times in a row. And the modification that I made from the original Randy experiment was, I'd said, students, little do you know, but I used to make money in college by making custom-made zodiac forecasts.
No one is surprised.
This is not true, however, but I would say this.
Sure it isn't.
And so, and I'd say, and then I went and spoke to the registrar, and I got all your birth dates, and I have created personal forecasts based on your zodiac sign for each member of the class. And then I hand them out with the names written on them. And I say, don't share it because it's very private. And then I say, I simply want you to rate it on a 1 through 5 scale, with 5 being like you nailed it and 1 being I don't know who this is about.
Can I guess?
You're crazy.
Can I guess?
And every year they score like a 4.5 4.5 to a 5
And
on
can I
average
guess?
across the class. And then I say, take it and hand it to the person next to you.
And it's the same.
And everyone has exactly the same horoscope in the class. And so, like, this is a group of students who've been in Global Health 702, where I've been trying to teach them skepticism and telling them that just because you hear something doesn't mean it's true. And this is now in week 3, and they fall right into the trap every year.
Yeah.
And I'm like, oh, man, that bums me out that they're so easily fooled by this. And yet,
I think we need to call it the Randy Gill effect.
Okay,
That
so
doesn't sound so good.
come, and your points being?
my point being is that
Or did
even
you
though
just
we
want to
do
tell
this,
us that story?
even though we
People
do
are
this,
gullible.
people are gullible. Even though we do this, I think the next step to knowing where this is going
okay, good.
is,
You are going
does
somewhere
this
good.
actually lead them to distrust things that they see
get there. We'll
in
get
the
there.
media, the popular media, or is it just like an effect on an exam?
And that I think is the key to what's missing here. And it's not necessarily criticism, as Don points out. I mean, you could be skeptical that they could even that you could even translate this information to kids this age, and therefore this is a important piece of information that we've learned that we are able to test to successfully teach kids to have this skepticism. But the question that I had was, is this the right outcome? Is being able to pass an exam on what we've just taught you?
It wasn't on what we've just taught you. It's on how do you take that information, synthesize it, and apply it to similar but new situations. That to me, I thought was different.
Yeah, and I agree with you. But if you go to did you look in the web table?
Yeah,
Really?
I did. I don't have it.
What does it say?
So web table 1. So this is they published their main tables in the study, but then they also published some findings online where they talk about the table of intended behavior. So the question is, think about an illness that you might get. Imagine someone claiming that a particular treatment might help you get better. How likely are you to find out what the claim was based on? For example, by asking the person making the claim, and you can answer missing, I don't know, very likely, unlikely, likely, or very likely. And there was a 10% difference in how much the intervention group would say they were likely or very likely to evaluate it, which is nice. It's important, but 10%,
Not that great.
64% compared to 55%. I mean, not clear. Other ones, showed other questions they asked were fairly
So you're saying
similar.
the magnitude of the effect is not as impressive as the final results indicate?
Right. I think the final results you were talking about are the regurgitation. It's not, I agree with you, it's not 100% regurgitation, but it's sort of let's go over the same material in a different way, as opposed to what do you intend to do with this information? And, there's you see less of effect. When you get to they ask self-efficacy questions. So how easy or difficult would you find each of these actions to be? So, for example, assessing where I can find information about treatments that is based on research studies comparing treatments, and there was only a 3% difference between the groups. Assessing how sure I can be about the results of a research study comparing treatments, and the intervention group actually was worse than the two groups. So I'm not convinced yet that this translates into behavior, and I say that because, when I sit down to watch TV, I intend to stop eating after 3 cookies, but there's a Gilmore Girls marathon on. Come on, I eat the whole box.
Yeah.
No, but I think we would all agree with you, and I think that
About the Gilmore Girls?
definitely not. Definitely not the Gilmore Girls.
You would agree with me that?
You don't like Rory?
That these results it's a bit of a stretch to translate these results into changes in health behavior.
But it's a good first step, and
Yes.
that's what I think. And it was a really, really well done first step.
So my take-home message is that for all of the anti-vaxxers, we should be having the pediatricians in Marin County in California be talking to the kids, not their mothers, about the fact that they need to get vaccinated.
There you go. Well done.
Yep.
And did you all look at the curriculum? I mean, it's really
It is.
Clever.
I thought it was really good.
impressive.
Yeah.
And there is actually a podcast that goes with it. In the Lancet, they actually published a cartoon that shows you should not be sticking your fingers into
Who?
poop, for lack of a better term, animal poop, generally speaking.
It was cow poop.
Cow poop. There you go. And then there was also a song. Did you listen to the song?
I did not.
I think it's
Was it a rap song?
if there's bias in your study and you know it, clap your hands.
Oh, no, please.
No. I don't. I don't. You can go online and listen to it, but it's quite a. It is. I wouldn't call it a rap song, but it's rap-esque. I really liked it. Can I? Before we close, can I tell you some interesting things I found about this study?
Yeah, please.
Okay, so under the amazing category, so this study, if I understood correctly, this study was done in June of 2016, the actual implementation, and this study was published in July of 2017. I mean, that's a really fast turnaround from finishing your analysis, finishing your study, doing the analysis, writing it up, and getting it into the published literature. And that's really impressive. I was a little surprised. Something that surprised me is, if I understood their sample size section correct, they said that they anticipated that 0% of kids in the control group would pass the exam in the absence of the intervention. They were expecting no kid would be able to pass this.
That's a little harsh.
I agree. In fact, it turned out to be something like 27 or 30, whatever. It was much higher than that. And that they powered the study to be able to detect a 10% difference. So they could detect anything bigger than that, but nothing lower than 10%. But 10% seems to me, if you only find a 10% difference, that's really small for something where you're going in and actively doing a teaching intervention, and then you're trying to determine whether or not they actually were successful. And then I put this one into the irony category. I think it's great that one of their claims, one of the things that they're teaching kids, is that it's best to, when you're evaluating a study, that the study is a blinded study, meaning that the participants don't know which group whether they got the intervention or they got the control comparison. And of course, this is an unblinded study, because it would be very hard to blind kids as to whether or not they got taught a particular curriculum. Now, you could teach them something else, I suppose. But I just found that it amused me that was ironic, if you will.
I think one of the other things that I noticed that they described was that they determined that it would have been $4 a student to put this curriculum into place, and that has to be contrasted with the $29 per student that the entire health education system spends in Kampala on primary education. So
absolutely,
it's a pretty hefty bill.
That's a lot. That's a lot to ask, but I think it is a pretty impressive finding. So is it safe to assume that we all really like this study?
Yes.
We have some concerns about how we would apply this to the rest of the world, but generally speaking, well done.
Yeah, no, definitely. It moves the needle. We liked it.
I think it does. All right, then with that, let's move on to our second segment, which is going to pick up on that exact theme. So what we want to talk about now is how we think about who the results of a study pertain to. It's a big leap that we have to make when we get to the end of the results of the study and we determine that we think it's a pretty good study. How do we then figure out, does it apply to everyone? So the example I always use is I could do the best study in the world that measured the effects of hormonal contraception for the prevention of pregnancy, and I could not apply those results to a population of men. Right? You'd think I was crazy if I tried to tell you about the effects of pregnancy prevention in men. But that's an easy one. But what about in a study like this? What do you look for to try and figure out who the results generalize to, and how do you draw those conclusions? So, and to start this off, Chris is looking skeptical, which tells me he didn't read my email telling him this was the topic for the conversation.
You sent us an email?
I think I might start with Don on this one, but let me just start
Dodges
with
that bullet. Yes.
Oh. Honestly, it is like running a daycare. So let me start. So
you said there were going to be no pop quizzes.
I was told there would be no math. So the study we just looked at, if you look at their methods, they excluded. It was a massive study. I mean, they went to schools all over. But schools that they didn't go to were schools that were difficult to access.
Yeah.
So they were harder, the schools that were harder to physically get to. Geographically remote. Does that, when you start to think about exclusions like that, does that change the way you think about who this study applies to? More generally, can we apply these results, do you think these results apply to school kids in the U.S.? Don, what's your take?
Yeah, no, Matt, it's always a tension. It's always a difficult balancing act between when you design a study, between designing a study that is going to be homogeneous enough so that you can have a meaningful effect, and generalizable enough so that if you find a meaningful effect, you can apply it to a population big enough so that it has some public health significance. So to answer your question, they did limit it. They excluded schools that contained expatriates. They excluded schools that had special needs programs. They excluded schools that they couldn't access that were very remote. But by the same time, they did include schools, they say, that were urban, peri-urban, and rural. So they made an attempt to try to address the generalizability just in terms of population density. They also included schools that were both private and public. So they tried to do that also. I think they made a reasonable attempt to address the issue of generalizability. And I think within that fairly large population, I would feel as if it was reasonable for those results to be applied to those particular areas. Beyond that, it becomes a little bit more problematic. But then if you take that to the extreme, as has been our experience sometimes, where there are a number of studies that have been done, say, on male circumcision in various different countries, for HIV transmission, heterosexual transmission, in various different settings, and we want to implement that in a country where that experiment was not done, or those trials were not done, and the Ministry of Health says it's not been done on our population, we need to do it. And in a situation like that, there's, in my opinion, unnecessary expense, unnecessary difficulty, and unnecessary delay in implementing something that we know works. Maybe that hasn't been tested in every single environment. So it's a difficult one to answer because there really are so many shades and nuances associated with it.
Yes, and I would agree with everything you just said there. Chris, when you think about this, so are there things that you think about that you're looking for in particular when you think about generalization? In other words, is it I'm going to look at the age and sex distribution of this population or the socioeconomic status, or is it sort of every study you're kind of making up the criteria on your own when you're trying to figure out who these results actually apply to based on who they excluded or included in their study?
Okay, so I'm now rubbing my bald spot because that's a toughie. I'm trying to think, like, what
take you a while.
What do I do?
We have time.
Yes, it's like rubbing the Buddha's belly, except much more satisfying.
Not for me.
You should try it.
No.
Anyway,
Gonna sit that one out. Hard pass.
I'm struggling. I don't know if I can give you a good answer for that. I suppose I do it on a case by case basis, but. I don't know. I mean, I guess looking at this one in particular, as I was reading this, I mean, one of the questions I had as I was going along is, I wonder why they chose to do it in Kampala, Uganda, because it seems that this is a sort of a universal problem that they're trying to focus on. Why Africa? Why Kampala? Why not South Africa? Why not Zambia? Why not Boston?
Well, they got to pick one place.
Why not? They got to start somewhere. And it's funny because in this paper they don't really explain at length why they did that. There's a one sentence blurb in there where they say, we did this because economically disadvantaged populations are more vulnerable if they invest resources in paying for interventions that are ineffective. So I guess that would sort of make the case for why a low resource setting. But honestly, this is something that's it'd be far more generalizable than just low resource settings. Because I think the issue of investing resources and time and money at an individual level or a household level or a societal level is the same everywhere.
So I think you're right. I mean, if we're talking specifically about the intervention that the study we were just talking about, the health intervention, the health literacy intervention, I suspect you are 100% right that this could work just about anywhere. The question is, would it work as well? That's what I think people are talking about when they talk about generalizability. It isn't, and so to me, what determines generalizability is whether there are factors within which the effects vary. So in other words, in this case, they specifically wanted to ask the question, does this work overall? But then they said, does this work better for kids who are highly literate? Or have strong reading skills, or I can't remember what exactly it was. Because if it did, it would say that there are certain populations in which you get a strong effect, certain populations in which you get a weak effect. You might think about, investing in this differently. With drug studies, you might find that the drug works better in men than women, or in certain races than in others. And that would tell you that if you decide to move to another population, you may not get the same benefit. So when I think about generalizing, it isn't just that I can, it isn't a yes, no for me. It isn't like I would say, we did this drug study in adults. It doesn't tell us anything about kids. It might tell us something about kids, but it doesn't tell us the whole story. When you start to looking at studies that sort of are averaging across populations, you have a study where it's 50% men, 50% women. It's mixed race. It's all of those things. It just tells you we need to know more about whether these effects are the same across all those individual groups before I start to make claims about this works for everyone. All I know right now is, on average, this is how well it works. Certain things translate better than others. So drug studies tend to translate from one population to the next better than do behavioral studies, because they're so
driven by the biology rather than
they're driven
sociology.
Driven by the sociology, and also the way that they're delivered. So who delivers? So for example, this one, one of the things we didn't touch on the last study we talked about is, who is the intervention? Is the intervention for the kids, or is the intervention the teacher? In which case the effects of the intervention, obviously it's the kids who get the knowledge, but are the effects entirely dependent on how good the teacher is? If the teacher's not very good, then you could take the exact same intervention in Uganda and find that it's not as good. And you could figure that out, because you could actually measure the effects by classroom.
Sure. To
try and figure out. And I would assume there's distributions, as there are anywhere. Good teachers, tend to be better with new things than teachers who aren't as good. So generalization is a tricky subject, but to me, it really depends on the nature of the intervention as much as it does the population who was in the study.
Mm-hmm. An interesting corollary of that is the concept of subgroup analyses. Mm-hmm. So if you do a randomized controlled trial of a drug, and overall you find that drug does not have an effect, but if you look at a subgroup of young men under the age of 25, or African Americans, or a lot of times that will be, in some people's minds, sufficient evidence that in fact the intervention worked in that subgroup. And I think that can be a real slippery slope, and we have to be careful to generalize from a subgroup a positive effect to the entire population, or even the entire population of that subgroup.
I agree. I also think one thing to be cautious about is subgroup analyses. So those are analyses in which I'm just looking at a subset of the population. I designed my study to look at the whole population. Don't always pan out. Things that we find in those subgroups often turn out to be chance findings or the odd finding. But that said, it's still important, I think, to be looking for those effects.
It's hypothesis generating.
Yeah, absolutely. I think you're right. So one last point I want to make before about generalizability. So I think when it comes to observational studies, so these studies where we don't actually control the intervention, I've expressed to you numerous times now that I don't always know what the question is, that what the intervention is. And like with the previous podcast that we looked at, we talked about the sugar substitutes, and I don't know what the question is, because I don't know if the question is, take these instead of, take these in addition to sugar. I don't know what the intervention is that you would recommend to somebody, and therefore it becomes very hard to generalize, because I don't know who the population that it's relevant to. But when it comes to trials, I think that we have the opposite problem, which is we have a very clear question, but who does it apply to? Because the question is so focused. So people who sign up to be in randomized trials, we have this healthy bias effect where people who sign up for trials tend to be healthier on average than the typical person. And so the information we get doesn't necessarily apply to the really sick people who probably would benefit most from this particular drug. It's often a healthier population. And so we don't always get the information that we need. We often find out the benefits when we apply them in sicker populations in the real world don't translate into what we saw in the randomized trials. So I'll just...
Not so much of an issue here, I'd say, with this study, because
Not at all.
They're randomizing the level of the school, and then the children in the school are sort of assumed to sort of go along with whatever the school has decided to do.
I agree. And this was a very applied trial. This was not a tightly controlled clinical trial like you'd have for a drug trial.
And actually, to get back to something that you said a little bit earlier,
which makes
Matt,
it more generalizable.
Me? Something I said?
Something you said.
This is going to be brilliant.
They actually did take into consideration what the teachers learned.
They did,
and they factored that into the analysis. So I think that they actually heard you ahead of time and dealt with that.
That's nice. It's nice when people listen to me retrospectively. All right, so that's, I think, all we have to say, and Chris probably didn't have much to say anyway on generalizability. Wish we hadn't taken on that topic, so we'll just move on. to our last and final segment, our Amazing and Amusing, where we want to highlight some of the things that, as we said, make us enjoy our jobs even more. The weird and wacky things that Don loves to the things that Chris says that I have to go and Google when we get back home.
I actually have one that relates to the paper that we just described.
Well, then you get to go first.
I get to go first. All right. So this is an article that was published in a journal that I'd never heard of called Judgment and Decision Making
Oh, yeah, no, that's a good one.
by Pennycock, Chain, Barr, Kohler, and Fugelsang.
Judgment and Decision?
Judgment and Decision Making.
Judgment and Decision Making.
Yeah, it's published in 2015. And the title of the article is On the Reception and Detection of Pseudo-Profound BS.
That is our theme.
I know. I thought it was just
Baloney,
really
malarkey.
prophetic. Hooey, malarkey. And so what they wanted to do was they wanted to determine whether pseudo-profound BS, which they define in a very particular way.
Would the definition be this podcast?
It could be.
Yep.
It could be.
Okay.
What they did is they took words that appeared to have a level of meaningfulness, and they
Made up words or real words?
real words.
Oh.
And they arranged them in ways that made syntactic sense. But the sentence itself really made no sense whatsoever. And kind of like Chris's Randy experiment, they asked people to comment on whether they were meaningful or not. And I thought it was really interesting because they used as an example a tweet that was put out by Deepak Chopra. And his tweet was, "Attention and intention are the mechanics of manifestation."
Wow, that's profound. What does that mean?
Wait.
Also, this concept of pseudo-profound BS has also been termed woo-woo nonsense. So anyway, so they conducted a series of experiments where they tried to correlate people's acceptance of the pseudo-profound BS with particular personality traits.
Who has the time for this?
I know. And so they did a series of experiments, and to make a long story short, they came up with a number of personality characteristics that seemed to be associated with a high level of acceptance of pseudo-profound BS.
Okay.
And one of them was, they called it BS receptivity. And they found that people who were less reflective tended to have a high BS receptivity, had lower cognitive ability, either verbal or numeracy.
Okay.
Had conspiratorial ideation.
Yep, I'm in there.
And had higher religiosity and belief in paranormal. And they were more likely to endorse complementary and alternative medicines.
Oh, yeah. Doesn't surprise me.
So
That is fantastic.
Their final comment in this paper was that there tends to be an association in acceptance of pseudo-profound BS with those who have an open mind, but they say, but not so open that your brains fall out.
Yeah, you got to be careful about that. Wow. You definitely got to be careful about that.
Wow,
It's
that's good
a
stuff,
keeper.
Don.
That is fantastic.
That's good stuff.
That's fantastic. Chris, what do you got for us?
Sure. This is a paper that was published just recently and got some press in the Proceedings of the National Academies of Science called Buying Time Promotes Happiness
Buying
by
Time.
Willans, Whillans, and colleagues.
Good thing you spelled that for us.
I was sitting at the soccer field last night, and I was chatting with one of my
Was there a soccer game going on,
soccer
or were you
mom
just
friends there, who is a professor at a different university in town, and was commenting on the fact that she just got all her groceries delivered by Amazon and was so happy. And she was so happy.
She bought free time.
Happy because she bought free time, right? And because we've all been taught that time equals money, but money doesn't equal happiness. But what these researchers have done in using meta-analysis, no less, was to show that, in fact, sometimes money does equal happiness, but it depends on how you spend the money. And so that they did this meta-analysis where they looked at observational studies equating quality of life indices with how you spent disposable income and whether you spent it on like paying someone to rake the leaves as opposed to going out and buying some fancy object. And there was a consistent effect that people's sort of happiness indices would go down when they bought things as opposed to when they bought free time, because you didn't have to rake the leaves. And then they did a little randomized controlled trial because they were skeptical of observational studies, and they found the same effect, that they gave people $40 and they were instructed to either spend it on a thing or spend it on paying someone to do something for you that you don't want to do. And then they measured their quality of life, and it trended up in each case. It was quite a cool little study, I thought. And it resonated. It really
resonated with you, right?
It rang true, shall we say.
No, I think that this really brings us back to the whole concept of generalizability, because I would imagine that the effect for this particular phenomenon would be much more pronounced in the top 1% or the top 0.1%, and much less pronounced in the lower 80%. People who don't really have time to purchase.
I don't know. I could see it being the opposite. That if you were,
it seems like it's a phenomenon of the idle rich or the non-idle rich.
I don't know.
It could be the phenomenon of people who work hard and have no time.
Yeah.
Or what about people? What about people that have a lot of time, but they don't value that time as much. So they're not willing to spend precious money to purchase more time because they've got a lot of excess time.
Plus, some people just enjoy working hard. I don't know who they are, but apparently
I've never met one.
Some people really enjoy it.
They certainly don't exist here. It's School of Public Health.
They do not. They do not.
What you got for us, Matt?
This one I got from the internets, so you can assume that it probably. I can't verify. I can't vouch for it, but this is one of those things that when we get comments back from reviewers on our manuscript, we often, I don't know about you guys, but I occasionally write things in response to the reviewers and then I delete them because they are...
Very often.
They are things that I never...
You mean you get unkind things said to you by reviewers?
I get unkind things said, and occasionally I say unkind things back that I don't ever hit the send button on.
And sometimes they're frankly nasty.
And hopefully I have deleted before I ever actually hit the resubmit button.
Knuckle scraping, is that one of those words?
So this is one that I can only assume was never actually sent, but was put out there on the internet as one of those things.
This is a reviewer's comment to a paper that was sent.
Letters never sent.
This is a letter never sent in response to a reviewer's comment.
Oh, okay.
Okay, and this is after presumably more than one revision of the paper. This is the thing we would want to say, but we don't actually ever say because we know it will get us into big trouble. So it says, "We hope you will be pleased with this revision and will finally recognize how urgently deserving of publication this work is. If not, then you are an unscrupulous, depraved monster with no shred of human decency. You ought to be in a cage. If you do accept it, however, we wish to thank you for your patience and wisdom throughout this process and to express our appreciation for your scholarly insights. To repay you, we would be happy to review some manuscripts for you. Please send us the next manuscript that any of these reviewers submits to this journal. Those things that you wish you could say, but you never would."
A little too pandering at the end. I think he should have gone full bore.
Yeah, agreed. So that is the end of our program. If you have any feedback on this or any other episodes, or you want to suggest a study or a topic for us to take on, you can tweet us at PopHealthEX. That's at PopHealthEX. So we're constantly looking for ways to improve the podcast. And to do that, we have set up a survey that we hope you'll go to and let us know what you think. So the survey you can find is at pophealthyex.org/FA, or you can just go to the pophealthyex.org website and find our page, and we'll have a link to it there. We hope you'll go on there and give us your honest feedback so that we can make this podcast even better. We want to thank Leslie Talalian, Director of Lifelong Learning at BU School of Public Health, for supporting the podcast, and Nick Guler for sound and editing. Thanks for joining us. We hope you enjoyed it, and we hope you download our next episode.